Abdominal swelling. Case. Dear Doctor. Bhavani Patil, aged 60 years. This woman came to see me today complaining of increasing abdominal distension. She has no very significant past medical history but has been seen intermittently over the past 3 years with complaints of lethargy and more recently has had difficulty sleeping due to itching. I am grateful for your assessment and advice. Yours sincerely. Introduction. It is unusual for abdominal swelling to be an isolated problem. There will often be additional symptoms or an easily identifiable associated history. The most important diagnostic consideration is ascites, the differential diagnosis of which and of other causes of abdominal swelling is given in Table 10. History of the presenting problem. The following features need to be determined: duration of the swelling, and the presence of associated symptoms such as pain, vomiting, constipation, weight loss or jaundice. Duration. Intestinal obstruction, paralytic ileus, and volvulus typically develop rapidly. Most cases of ascites develop over days to weeks. Fat, feces, fetal tissue and tumors accumulate over months. Fluctuation in the distension may suggest bloating associated with irritable bowel syndrome. Pain. The presence of discomfort due to distension with ascites is common, but constant pain may indicate inflammation or malignancy. A sudden severe pain associated with the development of jaundice would suggest hepatic vein thrombosis, Budd-Chiari syndrome. Colicky pain may suggest intestinal disease, particularly obstruction, and the association of pain with ingestion of food, particularly high fiber, would further support this diagnosis. Pain radiating to the back is typical of pancreatitis, a rare but important cause of ascites. Vomiting. The presence of vomiting suggests intestinal obstruction, particularly if in large volume, feculent, projectile or persistent. Change in bowel habit. Ask about constipation, particularly in the elderly, mentally ill, or those in residential or nursing homes. Ileus or intestinal obstruction results in diminished bowel movements or even total constipation, absence of passage of feces or flatus. In some instances, particularly in the presence of a stoma, the patient may notice a slowing of bowel function followed by explosive defecation in the instance of subacute obstruction. Weight loss. The accumulation of fluid in ascites will obviously lead to weight gain, but if the patient has lost weight or muscle bulk, then this may indicate an underlying malignant process. Patients with advanced alcoholic liver disease are also likely to have lost significant body mass. NB. The presence of jaundice suggests a hepatic cause for ascites, but remember that the absence of jaundice does not exclude it. Other symptoms suggesting liver disease, fatigue and pruritus are often presenting features of chronic liver disease, and present in this scenario. Other relevant history. Given that ascites related to chronic liver disease is the most likely diagnosis, it is essential to probe tactfully for evidence that the patient may have, or may be at risk of, chronic liver disease. After preliminary questions such as "Have you ever had jaundice or liver disease in the past?" it will be necessary to explore a careful alcohol history and explore risk factors for hepatitis C and B, including blood transfusion, pre-1992 and abroad, intravenous drug use and high-risk sexual behavior. Ask about other diseases associated with liver disease. Inflammatory bowel disease, especially ulcerative colitis, is associated with primary sclerosing cholangitis. Celiac disease and other autoimmune diseases are associated with primary biliary cirrhosis. A family history of liver disease should lead to consideration of hemochromatosis and other rare conditions. Clearly not relevant in this case, but a menstrual history should be taken from a younger woman, looking both for unexpected pregnancy and gynecological malignancy. Postmenopausal bleeding could clearly be significant in this case. Plan for investigation and management. NB. Many patients associate the term cirrhosis with alcohol. It is important to state that it represents scarring and can have many causes, which the tests will help to determine. Blood tests. Routine blood tests will include the following: FBC, hypersplenism, low platelet count, pancytopenia, alcoholic etiology, raised mean corpuscular volume. Electrolytes, urea and creatinine. Transaminases, alkaline phosphatase and gamma-glutamyltransferase. NB. Beware of the patient with alcoholic liver disease and urea or creatinine at the upper limit of normal. Very low levels are expected and a normal value almost certainly indicates significant renal impairment. Assessment of liver function. The best indicators of liver function are prothrombin time, serum albumin, and bilirubin. It would be highly unlikely that there is a hepatic cause for ascites if these are all normal. Assessment directed to the cause of liver disease. A non-invasive liver screen would be indicated if there were abnormalities of transaminases, alkaline phosphatase, or gamma-glutamyltransferase. In brief, this would include the following: viral serology, hepatitis B and C. Immunology, autoantibodies including antinuclear antigen, ANA, antimitochondrial antibody, AMA, smooth muscle antibody, SMA, and immunoglobulin levels. Serum ferritin, iron, and iron-binding studies. A ferritin level persistently greater than 1000 μg/L is highly suggestive of hemochromatosis and should prompt genetic testing for the HFE gene, abnormal in 95% of cases. Alpha-1 antitrypsin level. Copper evaluation, Wilson's disease. Alpha-fetoprotein, AFP in patients with known liver disease who decompensate, become jaundiced, encephalopathic, or develop ascites, unexpectedly consider hepatocellular carcinoma. NB. Ferritin levels are often elevated in liver disease irrespective of causation. NB. AFP may be normal in 10–20% of cases of hepatocellular cancer. Imaging. Plain abdominal radiograph. If bowel obstruction or ileus is suspected. Abdominal ultrasound. This may confirm the diagnosis of ascites, especially if the amount of free fluid is small. It will also provide evidence on the nature of the liver, size, texture, and the presence of focal lesions. The flow through the portal vein should be requested. Retrograde flow is usually indicative of portal hypertension and cirrhosis and will also determine the presence or absence of thrombus here, which may have implications for future management since it may preclude shunt placement or transplantation. Splenomegaly is suggestive of portal hypertension. CT and MRI. The suspicion of hepatocellular carcinoma requires imaging by either MRI or triphasic CT scanning and referral to the relevant hepatobiliary specialist. Other causes of ascites may be revealed, including ovarian masses and peritoneal thickening due to malignant infiltration. Acidic aspiration. Send for leukocytes, microscopy and culture, albumin, amylase and cytology. Spontaneous bacterial peritonitis, SBP, is a serious complication of ascites associated with chronic liver disease and is diagnosed by a leukocyte count greater than 250 cells/ml in the acidic fluid. Compare acidic albumin concentration with serum albumin concentration. A gradient greater than 11 g/L suggests portal hypertension, a gradient lesser than 11 g/L suggests an exudative cause, neoplastic, infective, or pancreatitis. Liver biopsy. NB. Percutaneous liver biopsy should not be performed in the presence of ascites. It is questionable whether any approach to liver biopsy is safe, but the best would be to drain the ascites and proceed to transjugular biopsy if a tissue diagnosis is needed. Management. In most patients, the presence of ascites should prompt admission for investigation and treatment. Specific treatment. Any specific underlying cause of chronic liver disease should be treated if possible, including abstinence in alcoholic liver disease, steroids in autoimmune hepatitis, and venesection in hemochromatosis. NB. Decompensated cirrhosis may improve if the insult, e.g. alcohol, is removed. Antibiotic therapy with equinolone or a third-generation cephalosporin should be initiated immediately in the presence of SBP. A patient with chronic liver disease and a history of previous SBP or a low ascites protein level, less than 10 g/L, should be treated with prophylactic antibiotics to avoid the condition. NB. Cultures in spontaneous bacterial peritonitis are often negative, and waiting for them should not delay treatment. Symptomatic management of ascites. The following therapies may be appropriate. Diuretics. Most ascites should be treated initially with a diuretic. Begin with spironolactone, and note that here is usually a delay of 2-3 days between introduction of the drug and initial effect. Careful use of furosemide may be required but can precipitate dramatic hypoatremia. NB. Significant renal impairment as well as hyperkaliemia can be induced by diuretics. Progress should be monitored by daily weights. Reduce diuretics if weight loss greater than 1 kg/day, and fastidious renal monitoring. Fluid and salt restriction. Restriction of fluid intake to 1.5 L/day is often recommended, as is salt restriction, but patients often fail to comply. Paracentesis. In the distressed patient or those who fail to respond to diuretics, therapeutic paracentesis is required. Recurrent reaccumulation of ascites may be an indication for referral for consideration of transplantation or portosystemic shunting, e.g. transjugular intrahepatic portosystemic shunt. Further discussion. Varices. Any patient with suspected cirrhosis or portal hypertension should be screened for esophageal varices. Albumin infusion. The benefits of human albumin solution in patients with ascites and renal dysfunction, or in those undergoing paracentesis, are controversial and poorly understood. In simplistic terms, it acts as a small volume plasma expander, improving renal perfusion and function in hepatorenal syndrome, 2 units/day, and prevents circulatory collapse in hepatorenal syndrome after large volume paracentesis. For paracentesis, 100 ml of 20% human albumin solution per 2-3 L drained is usually administered. General features. In routine clinical practice, the first priority would be determine whether the patient was acutely unwell, in which case acute intestinal obstruction would be the immediate concern. Patients with ileus, pseudo-obstruction, or constipation are generally less unwell, although they may vomit. Look for a sick bowl. Patients with ascites can be moribund, acute hepatitis, Budd-Chiari syndrome, quite well, chronic diuretic-resistant ascites, or anything in between. Massive organomegaly, hepatomegaly, splenomegaly, hepatosplenomegaly, or very large kidneys, can also cause abdominal swelling. In the context of a PACES examination, ascites and organomegaly are much the most likely diagnoses. From the foot of the bed, comment on the following. General appearance: is the patient well nourished? Alcoholic liver disease is often associated with muscle wasting, as is malignant disease, although this would be uncommon in PACES. Signs of chronic liver disease. Signs of chronic renal disease: arteriovenous fistulae in the wrist, S, or elbow, S, or signs of previous surgery relating to these, central venous dialysis catheter. Signs of hematological disease: petechiae/purpura, indwelling central line for chemotherapy. Abdominal examination. What is the nature of the swelling? Is the abdomen doughy, chronic constipation, gassy, tense, tympanic, ileus, pseudo-obstruction or acute obstruction, or fluid-filled, ascites, dialysate, or is the swelling due to organomegaly? In this scenario, in PACES, ascites is much the most likely diagnosis. Is there ascites? Check for shifting dullness, look for dressings, stitches or scars that might indicate recent paracentesis, note if there is umbilical eversion and or herniation. Is the patient on peritoneal dialysis, 10-cough catheter, or does he have a renal transplant, hockey stick scar in right or left iliac fossa with transplant kidney palpable beneath this? If so, take particular care to palpate bimanually for polycystic kidneys, and note that a large midline abdominal scar or extensive flank incision may indicate that one or both native kidneys have been removed. If the patient has ascites, then it would be appropriate to look for evidence of right heart failure. Is the JVP grossly elevated, and say that you would like to perform urinalysis to exclude nephrotic syndrome, heavy proteinuria. Also, note if the patient looks hypothyroid, although this would be a very rare cause of ascites indeed. Further discussion. What is the differential diagnosis of a patient presenting with ascites? Causes of ascites. Common: cirrhosis with portal hypertension, malignancy, severe congestive cardiac failure. Less common: Budd-Chiari syndrome, constrictive pericarditis, nephrotic syndrome. Rare: pancreatic disease, hypothyroidism, malabsorption, or other cause of hypoalbuminemia. How would you investigate a patient presenting with ascites? Diagnostic approach to the patient with ascites: acidic fluid, microscopy, malignant cells, infection. Chemistry: gradient of serum albumin from serum to acidic fluid of greater than 11 g/L suggests portal hypertension, gradient of less than 11 g/L suggests an exudative cause, neoplastic, infective. Culture, including for tuberculosis. Blood tests: FBC, liver function tests, bilirubin, transaminases, alkaline phosphatase, gamma-glutamyl-transferase, albumin, prothrombin time. Imaging: CXR, looking for evidence of malignancy. Ultrasound, to confirm ascites and to look at the liver and spleen and, if appropriate, Doppler studies of the portal and hepatic veins. Further investigations will be dictated by clinical suspicion and the results of initial laboratory tests, e.g. to pursue the cause of chronic liver disease, possible malignancy, CT scan, biopsy of abnormal tissue, or cardiac dysfunction, ECG, echocardiography.